Hi, my name is Samantha Soren, and I am a freshman at the School of Nursing at the University of Michigan. My patient today is a 19-year-old Caucasian unmarried female. Patient is a student at the University of Michigan, and usual source of medical care is University Health Services. My patient's chief complaint is shortness of breath as well as chest pain. Onset of shortness of breath was 10 days ago intermittently. Most recent onset of shortness of breath was 5 days ago. Dyspnea lasts from 5 minutes to 1 hour each event. For the past 4 years, they only occurred each dyspnea event once every few weeks, but now occur every few days. The onset of chest pain was 10 years ago intermittently. The most recent onset of chest pain was 5 days ago. Chest pain events occur in accordance with dyspnea. Chest pain described as a tight pain. Patient describes generalized pain around the chest area. Aggravating factors include dust and pollen. Patient believes that she is exposed to factors at an increased level within the past year due to changes in her living conditions, moving from a house to a dorm room. Other aggravating factors are exercise and being outside in cold weather, which also increased in the past year as previous living arrangements were in a warmer climate. Alleviating factors are rest and fresh air, but not cool air. Patient reports having used an inhaler when symptoms were first present, but has since stopped usage. Precipitating factors are stress and anxiety about schoolwork. When patient was first diagnosed, she was prescribed albuterol 90 mg inhaler, but is not used in the past 5 years. Patient complains that symptoms interfere with schoolwork. She claims to be unable to work during these events. Avoids exercise due to concern about symptoms flaring up. Symptoms also interfere with sleep. Associated symptoms include coughing, wheezing, and fatigue. Patient believes the problem is asthma. The patient's health history presents as follows. Patient was diagnosed with asthma when she was 8 years old. She was diagnosed with chronic sinusitis on 4 occasions. Once when 10 years old, once when 14 years old, and twice within the past year. Patient is up to date on all immunizations. Patient is allergic to dust, pollen, and cats. Patient has been hospitalized once at the age of 8 for shortness of breath, but has never been hospitalized except for that incident, as well as never had any surgical procedures. Patient is on no current medications. Patient denies any usage of drugs and/or alcohol. Patient sleeps around 5 to 6 hours per night, but wakes up with symptoms in the middle of the night. Has trouble falling asleep when symptoms are present. Does not have much time to rest throughout the day. Patient typically consumes 2 to 3 servings of fruits and vegetables per day, as well as 5 servings of carbohydrates, as well as 2 servings of protein. No recent change in diet. Patient consumes low intake of caffeine, about 1 cup of coffee every other day. Patient reports no use of safety devices. Patient has one older sister, 29, and a married mother and father. Patient keeps up positive interpersonal relationships with friends at school. Perceived stressors center around schoolwork as well as time management with friends in reference to schoolwork. Dorm room conditions may lead to aggravating patient current condition as well as cold air outside. She practices Jewish faith in accordance with conservative Jewish law, however does not keep kosher. Patient is currently freshman undergraduate student at the University of Michigan. Patient receives her annual physical as well as visits dentist twice per year. Self-care is evident. No foul odor, hair well kempt, and clothing clean. For the patient's family history, the patient's mother was diagnosed with asthma at age 10 and has history of anxiety within past 5 years. She is age 50 now. Sister was diagnosed with asthma in the past year. Father has history of high blood pressure within past 10 years. He is age 58 now. All grandparents have history of high blood pressure. Mother's father had asthma, however, patient is unsure year of diagnosis. Review of System 1. Respiratory. Patient complains of dry cough. Denies sputum with cough. Also denies any blood during cough. Patient complains of shortness of breath, typically during exercise and in other aggravating symptoms, dust and cold air. Patient complains of wheezing during cough and during events where patient has shortness of breath. Review of System 2. Cardiac. Patient complains of chest pain and discomfort as well as chest tightness. Patient complains of minor palpitations. Has shortness of breath during exercise. Patient denies difficulty breathing during rest as well as denies swelling around the chest cavity. Physical exam findings. Respiratory. Thorax color normal for race. AP transverse diameter 1 to 2. No injuries or deformities present. Thorax is symmetrical. No signs of distress in breathing, steady rate and depth in breathing. Trachea is midline, no palpable nodes or masses. Symmetric expansion, no lag in expansion. No tactile fragmentus present. Posterior palpation of ribs and thorax showed no sign of deformities, showed to be symmetrical. After listening to all lung fields anteriorly, laterally, and posteriorly, no rhonchi or crackles present. However, the adventitious breath sound, wheezing, is present in the lower left quadrant as well as the right lower quadrant. Bronchophony, egophony, and whispered petriloquy tests showed no sign of consolidation. Physical findings cardiac. No sign of heaves or lifts on aortic, pulmonic, herbs, tricuspid, or mitral areas. Contour of chest is even. After palpating chest, no sign of lifts or thrills on aortic, pulmonic, herbs point, tricuspid, or mitral areas. Could feel a strong pulse at PMI. After auscultating the 5 key areas with patient sitting up and again in supine, there were no S3, sloshing, S4, stiffness, or murmurs, poor closing of valves, present. S1, closing of the AV valves, and S2, closing of the semilunar valves, were present. Apical pulse was 72 beats per minute. After having patient lie on side, listened for any sign of S3 or S4, however, both were not present. First pertinent system, abdominal exam. According to the study, Proximal Reflux as Case of Adult Onset Asthma, Komatsu et al., 2013, it is important to assess the abdominal system because disorders related to the abdomen, specifically to the digestive tract, are associated with signs of asthma. The study was performed in order to see how anti-reflux surgery, or ARS, can affect adult onset asthmatic patients. As stated in the study, the prevalence of GERD in patients with asthma has been reported to range from 30% to 90%. Therefore, I find it necessary to perform an abdominal exam in order to see if a correlation exists within my patient who has asthma. Second pertinent system, HEENT exam. According to the study, association between asthma and risk of developing obstructive sleep apnea, Tiorescu et al., it is important to perform the head, eyes, ears, nose, and throat exam in order to assess the throat as well as the nasal passageways because of the relation to asthma in reference to obstructive sleep apnea. As the findings state, the risk of new onset obstructive sleep apnea is linked to asthma at an increased rate. Therefore, I find it necessary to perform the head, eyes, ears, nose, and throat exam to see if there are any findings related to obstructive sleep apnea in my patient.